Yes, good evening to all the participants. May we quickly have your introductions, please. First and foremost, I'm Dr. Denzel Lawrence from PhD 101, and today we've all gathered here and will be joining in the session for Dr. Bijivin's presentation on epidemiology of periodontal disease. So this little bit about our organization for the new participants here. PhD 101 is an online learning platform where we conduct continuous sessions for undergraduates and postgraduates alike. So every Wednesday or Thursday, we usually have academic topics where we will be taking upon rapid revision from various faculty members across the country. Apart from that, we also have certain extended sessions on the weekends where we would be interviewing and we'll be in conversation with various people who are connected with the public health scenario. So thank you everybody for joining in here. I can see Professor Dr. Sarvanan who's here. Good evening, sir. Can you hear me? If you could quickly introduce yourself to everybody else here. Meanwhile, we have Bijivin joining in. Okay. Hi, Bijivin. Good evening. Good evening. Yeah, can you hear me, Bijivin? Yes, Bijivin. Good evening. Yeah, Bijivin, can we quickly have a sound check? I think it's still logging in. Okay. Meanwhile, we have a couple of participants. Yes, Diksha Chaudhary, kindly introduce yourself. You can use the chat box. Let us know if you're a UG, PG. Yes, Doc?
Good evening, sir. Good evening, sir. I'm Dr. Diksha Chaudhary, final year PG student, Buddha Dental College, Patna.
Okay, nice to have you, Dr. Diksha. So you're a final year postgraduate student. Okay.
Yes, sir. Yes. Thank you, sir.
Thank you. Thank you for connecting with us, Dr. Sarvanan. Quickly.
Yes, Doctor. Good evening.
Good evening, sir. Kindly introduce yourself, sir.
Yeah. I am Dr. Sarvanan working in Vinaya Mission Salem. As a professor today.
Okay,
just want to listen Bijivin lecture today.
Okay. All right.
Good evening, Dr. Bijivin.
Yes, I think Bijivin is still connecting, sir.
Okay.
Anyways, thank you so much, Doc. Thank you for joining in and being a part of this. Thank you.
Yes, Doctor. Thank you. Wish you all the best.
Thank you, sir. Thank you. Yes, Gurunath. Can you hear me?
Yes, sir.
Yes, Gurunath.
Yes,
Gurunath
sir.
from?
Sir, from Maharashtra, MIT Dental College.
You're a UG student, I suppose?
Final year student, sir.
Final year BDS student? Okay.
Yes, sir.
Okay. So, Gurunath, so when are your exams scheduled to happen? Any tentative dates?
Sir, tentative dates are July ending or August.
Okay, July end or August. Okay, so MUHS is also giving you tentative dates.
Tentative. Yes, sir.
All right. Okay, nice. So you have been following our webinars regularly. I can see that.
Yes, sir.
So how do you find the content and the different teachers' experience?
Good, sir. Very good.
All right. Thank you so much, Guru, for joining in, and please stay logged in for the session.
Yes, sir.
Bijivin.
Thank you, sir.
Yeah, are you able to hear us?
Hi, sir. Good evening, sir.
Hi, finally. Okay, okay. Thank you so much, Jivan. I think one of your teachers, I think colleagues, is waiting to hear you. I think you can quickly say hi to Dr. Saravanan here, who's waiting for you.
Hi, sir. Hi, sir. Saravanan, sir. Thank you, sir. Thank you so much for joining.
Yes, thank you, Dada. Thank you, Dada. How are you, Dada? After a long time.
Yes, sir. I'm fine, sir. How are you, sir?
Fine, fine. Going on, Dada. Just I saw in a group today lecture, so just I want to take part of it.
Okay, sir.
If you don't
So
mind.
it's really
Yes,
nice of you,
sir.
sir. Really nice of you.
Okay.
Yes,
Thank
Dr.
you.
Saravanan, are you
Yes.
from public health dentistry specialty, sir?
Yes, sir. Yes, sir.
Oh, lovely, sir. Okay, good to know you, sir. I think pretty senior.
Yeah,
I
I
mean,
passed
never
out from JSS.
Mysore. Oh, okay. How that? Okay.
I am working for Vinay Mission Salem, Tamil Nadu.
Tamil Nadu, Salem. Okay, okay. All right. In fact, Tamil Nadu was the last trip. In fact, the ongoing current pilot series by
Yes,
Ramchandra.
it's going on.
Yeah. So last year, my last trip before the lockdown was in Chennai in February for pilot, actually.
Okay, fine.
So it was a
You're
really,
from
really
Bangalore,
pleasant
right?
experience.
Dr.
Yes,
Dempsey,
sir.
you're from Bangalore.
Bangalore, sir. Basically Bangalore. Working in Bapuji Dental College, Davangere. So
Davangere,
yeah,
okay.
I think born and brought up in Bapuji. So I've been here for throughout.
Okay. Good.
Okay, nice to have you, sir. Okay.
Yes.
Thank you so much. Okay. Yes, doctor. You want to say something?
Noted. Nothing. I can't be there for full time. Just I want to see Bijivin. That's why I came. Okay. I will try to be with you. Okay. Thank you.
Okay. Thank you so much. So we also have a couple of students joining in. Yes, Pavitra, kindly introduce yourself quickly. From which college, which year? And we also have.
I'm Dr. Pavitra.
Yes, Pavitra.
I'm an assistant professor at Sri Venkateswara Dental College and Hospital.
Oh, yes. Hello, doc. Hello, nice to have you.
Yeah, thank you. We met last year at Pilot.
I know. I if I could see you, I could recognize you. I can still look at an empty window.
Sorry, I've not connected to the video.
Okay, that's okay. I was just mentioning to Saravanan sir here about the pilot experience last year.
True.
And how much I'm missing Chennai from last year, man.
I suppose you had a great time last time because got to see your pictures.
Yes, very much. I mean, that was my first proper visit to Tamil Nadu or anywhere in Tamil Nadu, that is in Chennai. So I had my immediate junior, Dr. Mahesh, who is working in Karpavinayaga. So he was the tour guide for us. So he made sure we don't miss out. The whole 3 days in Ramchandra and Chennai was fantastic. And
Nice
you guys are good at what you do. And I can see that. And in fact, I had a chat with Akila ma'am as well regarding the ongoing pilot series. I mean, today I was able to take part a little bit in the sessions were going on. So it's really, I mean, IPHD Tamil Nadu chapter is very active and I'm really, very happy that it's happening this way.
Thank you so much. All credits to the seniors out there who are always motivating us and guiding us in whatever we do.
Absolutely,
and let me quickly say hi to Dr. Bijivin. Actually, he happens to be my junior.
Oh, is it? Jimin keeps appearing and disappearing, by the way, in class. I don't know, since the last couple of minutes.
Bijivin, are you there?
Yeah, I think he's away from the system. Nevertheless.
Hello, Ka.
Yeah.
Hi.
Thank you so much for joining.
Yeah,
how are you, Ka?
It's a pleasure. I'm fine. How are you?
I'm good, Ka.
How's your kid?
He's good.
Good. Nice to hear that.
A lot of fans we have for Jivin there. I didn't know this.
No, it's not like that.
We have
He's
senior
my
professors
senior.
and we have immediate seniors and juniors and everybody. I can see that he's quite a popular teacher. Okay, good, great. So, all right. So, welcome everybody again to PhD 101 Rapid Revision webinar series. Today, it gives me immense pleasure to introduce Dr. Bijivin Raj for everybody here. Now, I'd just like to give a little brief introduction about our guest speaker today. Dr. Bijivin, or we fondly call him as Jivin, is a public health dentist and social activist, presently working as assistant professor at Sri Mukamiga Institute of Dental Sciences, Kanyakumari, Tamil Nadu. He's a part of, sorry, he's a part of various non-governmental organizations working in the fields of disability, drug abuse, and de-addiction. He's done his master's in public health dentistry from Ragas Dental College, Chennai, and is currently pursuing his doctoral research in special care dentistry. That's ongoing PhD program at Sri Balaji Vidyapeeth, Pondicherry. His areas of interest are special care dentistry, e-health, drug abuse, and de-addiction. So thank you so much, Dr. Bijivin, for connecting with us and for accepting our invite to deliver this session today. We've given him a topic, which is again something which he's very keenly interested in, the epidemiological aspect of periodontal diseases. So thank you so much, Bijivin, for joining in, and welcome again all the other faculty, postgraduates, UG, PGs, everybody to the PhD 101 series. Yes, Bijivin, over to you. Can you share your slide, please? Yeah, I think you can do it now.
Yes.
To all our students and PGs who joined in, kindly let us know from which colleges you all are listening this to from. Use the chat box and feel free to put in your details there so that we know whom we are talking to, because this happens to be a mixed cohort. Yes, Jevin, I think we can see your screen now. Yeah. Could you put that on slideshow? Okay, let me just spotlight your video for everybody. All right. Okay. Okay, Jivan, I think it's about time. 6, we'll have a couple of students joining in and off. So I think we can keep the chat box active if anybody wants to have any questions. I'm sure Jivan will be very pleased to answer your queries towards the end of it. At the outset, I'd like to inform everybody attending this session that it's going to be a quick, rapid revision. This is in no means going to explore all the aspects, but Jivan is trying to make it really comprehensive from an epidemiological aspect and will help us understand the whole idea on prevention of periodontal diseases. Yes, over to you, Jivan.
Thank you, sir. Thank you so much for the opportunity. Good evening, everyone. So today the topic for discussion is epidemiology of periodontal disease. So these are the contents of my lecture: introduction, classification of periodontal disease, need for periodontal epidemiology, global periodontal disease burden, Indian scenario, periodontal disease among special population, epidemiological triad. So periodontal disease is one of the most widespread disease of mankind. No nation and no area of the world is free from it. The changing patterns of periodontal disease prevalence over a period of time are difficult to evaluate accurately because the methods and criteria of assessment may also vary from one study to the next. So we have different indices to measure the periodontal condition. We have gingival index to measure the gingivitis. We have periodontal index, Russell's periodontal index, which is a composite index, so that you can measure the gingivitis and the periodontal periodontitis. We have different clinical parameters like clinical attachment loss and the tooth loss due to periodontitis and the pathological periodontal packet depth. So we have different methods and different criteria. So all these makes it difficult to evaluate the epidemiology of an area or the country or the world. So epidemiology, as you all know, epidemiology is the study of the distribution and determinants of health related and the application of this study to control of health problems. So why it is important? Why epidemiology is important for clinician? To get the answer for the questions, Like, is this a rare or common condition? When a patient comes to your clinic, does my patient fit the profile of people likely to have the disease? And where on the continuum of normality to disease are the signs and symptoms I see in my patient? What is the natural history of the disease I'm treating? And what is the prognosis? And what are the different treatment options available, which found through the epidemiological studies? So, for all these things, a clinician must know the epidemiology. This topic may not be an interesting topic, but we have the by understanding the prevalence, the distribution of this particular disease, you will understand the need for more epidemiological survey in this particular context. So let's come to the periodontal disease. Gingivitis and periodontitis are the most commonly seen periodontal diseases. So gingivitis is the inflammation of gingiva in which the junctional epithelium remains attached to the tooth at its original level. Periodontitis, this word comes from Greek. Peri means around, odus, tooth, and itis is inflammation. It is a set of inflammatory disease affecting the periodontia, that is, tissue that surround and support the teeth. Periodontitis involves progressive loss of the alveolar bone around the teeth, and if left untreated, can lead to the loosening and subsequent loss of teeth. So, this is the classification of periodontal disease. So, we have gingival disease, under which we have plaque-induced gingival disease and non-plaque-induced gingival disease, chronic periodontitis, localized and generalized, aggressive periodontitis as a manifestation of systemic diseases, abscesses of periodontium, periodontitis associated with endodontic lesions, and developmental or acquired deformities and conditions. So these are the different diseases comes under dental block-induced gingival disease, and these are different diseases comes under non-block-induced gingival diseases. So the prevailing model for the epidemiology of periodontal disease include these persons. All individuals were considered more or less equally susceptible to severe periodontitis. Gingivitis usually progress to periodontitis with subsequent loss of bony support and eventually loss of teeth. Such that the main cause of tooth loss after age 35. And by in different epidemiological studies, you may see increasing the age, the disease also get worsen. So we may understand it like there is a relationship between the age and the disease, but it is not like that. So the disease will start at the age of 35 and it get worsen in the age of 50. So periodontitis is an accumulation, it's a cumulative effect of gingival destruction started at the age of 35. So need for more periodontal epidemiological studies. So inflammatory periodontal disease or almost there everywhere, and the progression of the disease is not fully understood. Loss of tooth supporting apparatus is essentially irreversible. Lack of pathognomic features and the multifactorial etiology. So let's move to the natural history of periodontal disease. This is one classical study conducted in Sri Lanka, started in the year 1970. So total of 480 male tea laborers between 15 and 30 plus years of age who were healthy and well built were selected, and the workers had never been exposed to any programs or incidents related to prevention or treatment of dental diseases. Their toothbrushing habits and all was unknown. In the year 1970, 71, 73, 77, 81, 85, and 89, clinical examinations were conducted by two periodontists who are well trained was done, and the results were recorded. So at the end of the study, 70% of the 15-year-old Sri Lankan have no or very little loss of periodontal support. However, approximately 30% exhibit localized lesions measuring between 2 and 9 millimeter, and more than 1% have one or more root surface with 10 loss of attachment or more. At 30 years of age, the mean loss of attachment is 3.11 millimeter, and approximately 25% of the T-labers have lesions extending 10 or more below the cemento-enamel section. So this study suggests that without interference, the periodontal lesion progress at a relatively even phase, and that the progress is continuous. So this is one study conducted after 40 years, measuring the tooth loss due to periodontitis. So periodontitis related tooth loss over 40 years varied between 0 and 28 teeth among the 75 participants who were participated in the original study. So 4 subjects presented with no tooth loss while 12 were adventurous. These results highlight the importance of treating early periodontitis. Calculus removal, clock control, and the control of gingivitis are essential in preventing disease progression, further loss of attachment, and ultimately tooth loss. This is the result, and this is the natural history of periodontitis. So let's move on to the global burden of severe periodontitis. So generally, in most of the studies, like DMFT, in epidemiological studies related to periodontal diseases, they measure and view the data as sites with loss of attachment or clinical attachment loss. So this table shows the prevalence of periodontal disease among different parts of the world. So the highest among the southern Latin America, that is 20.6. So this is a survey report by WHO among their different regional offices. The first graph is about the CPI score in 15 to 19 years old, and the second is about 35 to 44 years. So you can see the zero, that is our Southeast Asian regional office. Score CPI score 2 is very high, that is supragingival and subgingival calculus. And likewise, in the age group 35 to 44 also, the CPI score 2 is more among the Southeast Asian regional office, that is India and the neighboring countries. So here I have given some results of various studies. The studies conducted in Sweden. So the result is no subjects had gingivitis. Its prevalence increased with age. Severe periodontitis was at almost 88% of subjects, and Japan, United States. So everywhere there is a uniformity in the disease prevalence. So about Indian scenario. So, Indian National Oral Health Survey and Fluoride Mapping 2002 and 2003. So, these are the prevalence of periodontal disease among different age group. So, it is high. So, this is a report of the multicentric study carried out under the Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India, and WHO collaborative program. So this survey is conducted in 7 different geographical locations in India. So in the 35 to 45 years and 65 to 74 years age group, high prevalence of periodontal disease was reported in the states like Orissa and Rajasthan. It's like everyone has the disease. So the prevalence of attachment loss in the 35 to 44 years group was highest in Maharashtra, 78%, followed by Orissa 68 and Delhi. So this is a classical study conducted in India by John C. Green. So at the end of the study, he found 97% prevalence of periodontal disease. And this is one of the earliest epidemiological survey conducted in the 1940s in India. They found 83% prevalence of periodontal disease among men and women from Mumbai. So these are different studies among different populations. So Ranganathan et al. Conducted a study among HIV positive patients and found periodontal breakdown more in HIV positive patients. So other studies also expressing the same conclusion. So this is one study conducted among transgenders, and it was found 87.3% with calculus and shallow packet contributing major part, that is 67%. So this study was conducted by Dr. Saravanan sir among transgenders. So the prevalence of periodontal disease was 83% with bleeding gums, calculus, pocket, and everything. So this study conducted among special children, and in this study also they have proved that periodontal disease is more among special children. So this is about a tribal population in Java the Hills in Tamil Nadu. Most of the population in all age groups showed presence of calculus, and the shallow packet of the 4 to 5 mm were seen among a significantly larger section of the 35 to 44 age group. So this is a study conducted among prisoners, and it is also to high prevalence of periodontal diseases. So that's about the distribution of periodontal disease in the world and in India. Let's see about the determinants. So epidemiological trial, host factor, agent factor, and environment factor. So we have a lot of host factors. Today I'm going to concentrate more on these host factors: age, sex, race, tooth anatomy, habits, alcohol, tobacco, socioeconomic status, systemic conditions, diet and nutrition. So aging is associated with an increased incidence of periodontal disease. This is what proven many studies. So this is the periodontal disease trends in US. So sorry, UK. The number of children with plaque and debris on their teeth increased steadily between the age of 5 and 8 years, reaching a plateau before decreasing slightly to the age of 15 years. So this is the finding among children, and this is the continuation. And this is a comparison of studies conducted in Norway and the Sri Lanka. And this table shows the mean annual loss of attachment rate in different age groups in two different studies. But the question has been raised as to whether age is only a marker for the accumulation of bone and attachment loss, or whether the destruction is actually a part of the physiology of aging. Actually, age is an unmodifiable factor that does not allow any intervention. It cannot be considered as a risk factor, but remains a demographic factor for the disease, which must be controlled for in assessing other potential risk factors.
Jivan, we are unable to hear your audio.
Yes. Sorry. So the next is about the gender. So numerous studies reported higher periodontal destruction among males compared to the female population. The reason for these sex difference are not clear, but it is thought to be related to poorer oral hygiene level, which is usually observed among males. That is what. But few studies proved that there is no difference in prevalence of disease among gender. So the next is about the race. So Chinese display the highest prevalence of self-reported periodontal disease, followed by blacks and whites, with Hispanics display the lowest prevalence. So blacks are most common affected than the whites, according to Russell. So Vietnam Hill tribal shows twice the severity of disease found among the regular Vietnamese. But in our country, in Indian scenario, there is no much difference between the race or among the people who are living in tribal areas. So different races will be there. So there is no much difference. Then diet and nutrition. Sticky foods may interfere the self-cleansing process of oral cavity, and deficiency in nutrition like vitamin A, B complex, D, calcium, and phosphorus has higher prevalence and severity of periodontal diseases. The tooth anatomy, like poor cusp, uneven marginal ridges, crowding, can cause food impaction and irritation of underlying tissues, and that causes the gingivitis that can lead to periodontal disease. And the frenum, if inserted close to marginal gingiva, it can cause recession of the interdental papilla, and that also a reason for recession and periodontal diseases. Then local irritants like mechanical irritants like faulty toothbrushing, it can cause abrasion or recession of the gingiva. Faulty restoration, it can cause it can impinge the gingiva or irritate them, and it can cause gingivitis. Like chemical irritants, alcohol, usage of tobacco can directly lower the resistance and increase gingival susceptibility to gingivitis and periodontal diseases. And other atmospheric irritants like obstruction in the nasal passage, malocclusion, habits can lead to lower tissue resistance. And genetic factors like identical twins and isolated populations suggest 50 percentage of susceptibility to periodontal disease. And indigenous and relatively isolated population have been shown to develop distinct periodontal disease that differ from group to group. Uh, so, first report identifying a genetic component in periodontitis appeared in 1997. So, data from patients in private practice was used, and they found that a specific genotype of polymorphic interleukin 1 gene cluster was associated with more severe periodontitis. So, this relationship could be demonstrated only in non-smokers, which suggests right away that the genetic factor was not as strong a risk factor as smoking. So it's identified as a contributory cause of periodontitis among some patients. At the end of one study, the study among 169 twin pairs concluded that about half of the variance in periodontitis was attributable to heritability. At the other end, there were no difference in tooth loss attributable to IL-1 variation over 10 years in a non-smoking, well-maintained population. So tobacco The population risk due to cigarette smoking has been studied in large surveys, and it is estimated that in the US population, approximately 42 percentage among current smokers and 11 percentage of periodontitis among former cigarette smokers. So the odds ratio of developing periodontal disease among smokers range from 2.5 in one study, 3.97 among current smokers, and 1.68 among former smokers in one study, 3.25 for light smokers to 7.8 for heavy smokers in another study. So alcohol. So in the recent researches indicates that excessive alcohol consumption is associated with increased severity of the periodontal disease. It's an assumption that alcohol use, tobacco, and the unhealthy diet all commonly go together, and it causes the disease. And people who consume tobacco or alcohol are more likely to tobacco are more likely to drink alcohol, eat a diet high in fats and sugars but low in fibers, and people who have a high consumption of tobacco and alcohol thus more likely to be higher risk of severe periodontal disease and oral cancer. And different systemic factors, like many systemic factors and disease have been implicated as a risk factor for periodontal disease. It's usually it's two-way, like infective endocarditis and diabetes mellitus. So in some cases, they directly do cause dissection, but impair the post-immune response. So diabetes mellitus. So the association between diabetes and periodontal breakdown was found to be inconsistent in a number of studies. Some studies have found no or little correlation between the two diseases, but in some larger scale population studies have shown a greater risk for periodontal disease among diabetes. So a cross-sectional study conducted among Pima Indians. So this is a tribal group in United States. So the high level of blood sugar. That so in this group they display a highest prevalence of type 2 diabetes in the world, show an odds ratio of 2.8 to 3.4 for developing periodontal disease in type 2 diabetes and diabetics compared to non-diabetics. Socioeconomic status. So generally, those who are better educated, wealthier, and live in more desirable circumstance enjoy better health status than the less educated and poorer segment of society. This has been proved in many studies. Periodontal disease are no different, have been related to lower socioeconomic studies, economic status in few studies. So let's move on to the agent factors. So the plaque and calculus. So this dental plaque can be defined as the soft debris that form the biofilm adhering to the tooth surface or other hard surfaces in the oral cavity, including removable and fixed restorations. So this materia alba is a soft accumulation of bacteria and tissue cells that lack the organized structure of dental plaque and are easily displayed with a water solution. So calculus is a hard deposit that formed by mineralization of dental plaque and is generally covered by a layer of unmineralized plaque. So dental plaque is broadly classified as supragingival or subgingival based on its position on the tooth surface. So supragingival plaque is found at or above the gingival margin, and the subgingival is found below the gingival margin between the tooth and the gingival sulcular tissue. So 1 gram of plaque contains approximately 2 into 10 to the power 11 bacteria, and it has 500 distinct microbial species. So the initial bacterial colonize the pellicle coated tooth surface are predominantly gram-positive facultative microorganisms like Actinomyces viscus and Streptococcus pyogenes. So these initial colonizers adhere to the pellicle through specific molecules and adherents on the bacterial surface that interact with the receptors in the dental pellicle. So cells of uh, Actinomyces viscus possess fibers, protein structure called fimbriae that extend from the bacterial cell surface. So these protein adhesions on these membranes specifically bind to proline-rich protein that are found in the dental pellicle, resulting in the attachment of bacterial cell to the pellicle coated tooth surface. So this block, we have different hypotheses. Uh, so the first one is the non-specific block hypothesis. Here, the uh, when only small amount of plaque are present, then noxious products are neutralized by the host. So the large amount of plaque would produce large amount of noxious products, which would essentially overwhelm the host defenses. So the treatment of periodontitis by debridement and oral hygiene measures focus on this removal of plaque. This product is found in the and is founded as the non-specific plaque hypothesis. So in this specific plaque hypothesis, the only certain plaque is pathogenic, and its pathogenicity depends on the presence of or increase in specific microorganisms. This concept predicts that plaque harboring specific bacterial pathogens result in periodontal disease because these organisms produces substances that mediate the destruction of the host tissues. So microorganisms associated with specific periodontal diseases. So the bacteria cultivated from periodontally healthy sites consist of gram-positive facultative rod support. And the recovery of this group of microorganisms is decreased proportionally in gingivitis and periodontitis, and it is replaced by gram-negative rods. But identification of bacterial pathogen in periodontal disease has been difficult because of number of factors, because of the complex community of the microorganism. Pathogen in one site also may be present in low numbers in the healthy sites. So, and the chronic nature of the disease, so it makes it difficult to identify the bacteria. So bacterial color complex. So these are the different bacteria present in the periodontal diseases. Here, this early colonizers are either independent of defined complexes or members of the yellow or purple group. And the microorganisms primarily considered secondary colonizers or comes under green, orange, and red complexes. And this green and orange complexes include species recognized as pathogens in periodontal and non-periodontal infections. So these are the different pathogens present in periodontal diseases. Yellow and blue comes in the primary colony, and then the red, orange. So next is oral hygiene and periodontal disease. So Russell considered his finding on periodontal disease in South Vietnam to be representative of the findings on periodontal disease for the whole survey. So in this survey, they found that there is a relationship between the oral hygiene and the periodontal disease. And in the natural history of periodontal disease study conducted among Sri Lankan population also showed that there is an association between the attachment loss and the dental calculus. So, maintenance of oral hygiene can improve the periodontal health, and if we are not maintaining properly, it can lead to periodontal disease. That is what the findings of these studies. So the next is about the environmental factors. So under which geographic variations, degree of urbanization, stress, and other psychological issues. So geographic variations. So periodontal disease are reported high in uh, few countries, and it is very low in few countries. So all those things we have seen in the global trend, and this is what given this slide. And degree of urbanization. This could, however, be because of oral hygiene practice, diet, and the socio-economic status and inaccessibility to dental care. So, if you see the distribution of dentistry or the dental health centers in India, so most of the time we discuss about it. So, we are mostly the dental care is available in the urbanized area, so that people from that area will get more chances for meeting the dentist and getting good treatment for their oral conditions. But uh, this accessibility won't be there for the rural conditions. Uh, but still, the prevalence study in the rural and urban subjects of Louisiana, they found that the urban subjects had higher prevalence of moderate and severe periodontitis as compared to rural subjects. This may be a result of uh, the lifestyle changes, and this is a study about the prevalence of periodontal disease among rural population. They found maximum numbers of subjects were in the age group of 35 to 45 years, and the prevalence of periodontal disease was found to be 73.62%. The periodontal status deteriorated with aging. The prevalence of periodontitis was higher in females compared to males. So the next is about the quality of life and periodontal disease. So the quality of life impacts among patients with periodontitis using oral health impact profile, and found trouble pronouncing words and taste affected 93.5 percentage, painful and uncomfortable to eat 91.4 percentage, being self-conscious and felt tense 95.7 percentage of the people with periodontal disease have stated they have all these problems. So, periodontal disease is affecting the quality of life. Next is economic burden of periodontitis. So, the more severe, the more costlier. A study conducted in US, they have given the result that the annual loss due to periodontal disease in US is 149 0.53 billion euros, and in UK it is 122.65 billion euros. So this is the loss due to periodontal disease. You can save all this if you are getting the treatment in the earlier time. So the more severe, the more costly. The use of periodontal epidemiological data. So we generally stop the periodontal, the second part of the definition of epidemiology, application of the study to control the disease. know, with clock control measures, toothbrushing, and everything. But it should not be stopped at that level. It should be taken to the next one, because it is causing economical burden and it is affecting the quality of the life. So the data should be used for developing some public programs to control the disease. The disease prevalence is very high. That is, it's almost 100 percentage in rural areas of India and other countries, and it is there everywhere. So all these data should be used to develop some preventive programs to control this disease. So the population strategy uses a community-wide approach which health education and other favorable life practices are introduced in the community, and unfavorable behaviors are attempted to be changed. So the secondary prevention strategy includes detecting and treating individuals with distracting periodontal disease, where at least we can try to limit the disease, and the identification of high-risk group of periodontitis, the early detection of active disease, and the identification of subjects and groups who are more likely to develop restrictive periodontal disease in the future, or important elements of dental care system plan. So that should be identified, and we should work on that. We in our country, the study conducted by Sudhakar and Gavli in the uh, 2014. At the end of the 2020, there will be 1 lakh excess dentists in India. So we, based on that workforce model and all, we have excess dentists, but still the disease burden is also very high. So we should think about the places where we are lagging in providing service, and we should plan for that, and that should be corrected. So conclusion: adoption of better oral hygiene should be a notable impact on the occurrence of periodontal disease. Awareness of awareness of the occurrence of disease, the infectious nature of this disease, and the available means of risk assessment and disease prevention may be achieved through a better interaction between oral health providers and community decision makers, and changes in the educational programs in the population to promote healthy attitudes. So all these things should be there. So it is causing a huge economic uh, uh, issues, and it is affecting our day-to-day life. There is a link between the general health and the oral health. So periodontal disease plays a very important role in that. So considering all these, policymakers should think about this, and should formulate some new programs for that. So, and as I told you, the need for epidemiology. So we are lagging in so many things. We don't have a standardized method to assess the periodontal epidemiology. So when policymakers asking us for some data regarding this, we don't have a uniform data. So we cannot give a proper epidemiological data for that. So we are in need of some standardized method to assess the periodontal health, and all these things should be uh, carried out. So these are my references. Thank you.
Thank you so much, Dr. Jivan. I think in this session, it was quite comprehensively covered. Now, the various aspects, students, for all of you who are attending this, right? What needs to be understood is, as Jivan mentioned and explained here, we need to understand the etiology of periodontal disease, keeping in mind the epidemiological triad which was specified, and also the various case studies which are very helpful for us to understand the context of periodontal disease burden across the world. And this actually holds true even when we look at the global estimates. So there is a need for periodontal epidemiology because the only way we could overcome and actually successfully reduce the periodontal disease burden is by addressing the causes of causes. Now, the root cause can be assessed only when we have in-depth epidemiological evidence, again, among the general population, among various special populations, where there are differing needs and requirements are constantly seen. So I think Dr. Jivan gave out a very lucid explanation for all of the content today. Before we move on to the question answer sessions, I request all of you all to please let us know if there's any specific questions you all want to see. Before that, I would like to share some content with the rest of the audience here. Yes, Jivan, are you there? Yes, Jivan.
Yes, sir. Yes, sir.
Yeah, Jivan, I just wanted to share some one technique of periodontal risk assessment, since you mentioned and also you put it in your conclusion slide.
Yes.
So I would want to just put this across and also show some perio tools which are available. Okay, is my screen visible?
Yes, sir.
Okay, all right. So guys, here there is a website called periotools.com, okay, which actually helps you ascertain the periodontal risk assessment for individuals. I think, have you all heard about karyogram? Please let me know in the chat box. How many of you have heard about karyogram for dental caries? Yes, no, quickly. Anyone here? Okay, yes, Dr. Deepak, he has. Anybody else? Very similar to karyogram, right? Like how we have various factors, how we can assess the dental caries probability. We have something called periodontal risk assessment here. And yes, Dr. Deepak, you'd like to, yeah, let me just allow participants to unmute themselves. Okay. So quickly going through this, right, you could actually enter the details of the patients here randomly. If you could just have this as a chairside assessment tool. Now, what you're seeing here is the polygon surface area, and in terms of the periodontal risk is high, medium, and low. So the main deterministic factors here are all derived from epidemiological evidence, starting from age, the number of teeth or the implants which are placed, the number of sites per tooth or an implant which are involved, the bleeding on probing, positive sites. You need to add up here based on all the in-depth evaluation. Then again, there is pocket depth and the number of missing teeth. And then we notice the bone loss and presence of any systemic or any other general complications. In the environmental factors, they've cornered down on whether the patient is a non-smoker, former, occasional smoker, or a heavy smoker. So based on this, there is a recommendation and it is given and is mentioned. So this could be a very simple tool which you could use on a chair side, and you can take in details and try to find out the risk assessment. All right. Now, apart from this, I'd also like to show you all some videos so that you all can actually get a better idea as to the whole etiology, what Jivan was explaining to all of us here. Now, as the gums show the signs of inflammation, now we need to know the various stages in the sequelae of gingivitis. So as this video is representing and showing us here, the clinically detectable lesions. So once the patient is not motivated enough, this is the basic etiology. So whatever gets accumulated. So a lot of patient education is required in terms of periodontal disease, because the general public has got a fairly decent advanced understanding of dental caries, but with respect to periodontal disease, we need to create more awareness, and that's when we can actually use a lot of these videos for your patient education and motivation. Yes. So, like I was mentioning, I think the more we understand periodontal disease and the epidemiology behind it, that gives us a basis for the expansion in terms of how we can prevent and control diseases in various other things. In fact, some of the very valid points which were mentioned by Jivan here relate upon how the periodontal disease are now consistently or correlated with many of the systemic diseases. So we notice that there is plenty of evidence which is available to us in this direction, so that we understand and then we able to give this information to our patients, that for example in conditions like diabetes mellitus or any other cardiovascular diseases, so there is established evidence which is available in this regard. So for most of the postgraduates here, if you're keen on knowing what are the main questions, periodontal conditions and the oral health in terms of the various systemic conditions. Yes, Jivan, I think if you could just add a small note on the commonly asked questions in this topic for the undergraduates who are attending this.
Yes, sir.
The major universities, the commonly asked questions, the main questions, short essays. If you could just give your inputs on that regard, because
Yes,
we have
sir.
a lot of final year students.
Yes, sir. Like the flow control can be asked for undergraduate level, disclosing agent, and the like mechanical flow control, different toothbrush. Actually, that was my library dissertation. Mechanical toothbrush, mechanical flow control, different types of toothbrushes available. So,
Okay.
and
So from an exam point of view, I think it's really important for us to read this topic, in terms of epidemiology. Like today, we were able to cover the epidemiology of periodontal disease. So prevention and control, like all of the questions related to dentifrices and mechanical and chemical and disclosing agents and triclosan and chlorhexidine. There are so many more questions which could be commonly asked from this. So from an exam point of view, this is very, very important and essential. All right. So any questions, participants, anything you'd like to ask Dr. Raj here, be able to give you some clarification? Anybody would like to ask any specific questions? How do we write a main question or short essay? You can use the chat box and let us know so that we can put this across.
Good afternoon, sir.
Yes, yes.
Sir, I wanted to know the how this periodontal disease is associated with the preterm labor in pregnancy.
Okay, so Dr. Deepak wants to know that the association of periodontitis related to preterm labor and pregnancy. Yes, Jivan, I think you can go ahead and answer that. There's a lot of literature for that. Because there's
yes,
a lot
sir.
of evidence. Yes, Jivan,
Yes, sir.
please.
It is proved. It is a proven that the relationship between preterm labor and periodontitis, and the habits of uh, the uh, and the and it is reversed, like the maintenance of oral hygiene by the mother during that pregnancy period is also will affect, and it leads to preterm labor. So
Yeah.
it's two way. It is proved in many studies.
Yeah. Just adding on to what Dr. Jivan is mentioning about periodontal disease, like as we know it, is a chronic inflammatory response, right? So a lot of maternal health conditions are associated with chronic, decrease in all of these conditions. Now, there is established evidence which has linked periodontal disease and preterm, low birth weight, also preeclampsia. And again, whether this relation is causal or it is inverse relation, it is still to be, exactly determined by this. But yes, there is a tantamount amount of evidence in this direction. So we can come across, in fact, there are a lot of studies published, Deepak. I think you can just go in detail and see that the prevalence of periodontitis is normally very high in pregnant mothers. And again, in that, there are 7 or 8 times higher risk of having preterm or a low birth weight baby. Again, it could be the hormonal changes during pregnancy, which could facilitate the occurrence of such kind of periodontal disease. So there's a lot of information in that. So I think that should answer your question. Yes, Deepak? All right. Any other questions, guys? Anything else specifically you all want to ask? Meanwhile, I think if I could share another small video which was related to periodontitis and diabetes mellitus.
We know that if you have low-grade chronic inflammation in the bloodstream, it does tend to predispose to diabetes. The evidence base for an association between periodontitis and diabetes is very strong indeed.
We know that diabetes is a risk factor for periodontal disease. Periodontal disease appears to be a complication, an infectious complication of diabetes mellitus. We and others have found that patients with diabetes who also suffer from periodontal disease often have worsened glycemic control.
There are some studies showing that the HbA1c levels in blood can be dropped by 0.4%, which doesn't sound a lot, through periodontal treatment, but it's the equivalent fall from an anti-diabetes drug used as a second drug in addition to the primary drug. If you offer patients a drug or you offer them a physical treatment, they would far rather have the physical treatment. They don't want to be on the drugs. Periodontal disease is relatively straightforward to treat. The treatment's accessible, doesn't take too long, and it's, by and large, it's effective.
So yes, guys, that was a small video highlighting the important relationship between diabetes and periodontal conditions. Now, as we see the increasing prevalence of non-communicable diseases and the transition or the change in the trend that is from the communicable to the non-communicable diseases, I think it becomes all the more imperative for us to identify the risk factors, the etiology, understand the epidemiology of periodontal disease to a far greater extent than what we know as of now. Mainly because there is a lot of research which is upcoming in this area. In fact, I think most of our periodontists will be able to add more content and context to this. And when you look at it in terms of a public health problem, simply because the prevalence is so widespread, and today the leading cause for tooth loss happens to be periodontal conditions. So if you look at a preventive aspect here, I think the epidemiological approach in terms of using a common risk factor approach or making sure that patient get more aware about various other factors influencing the occurrence and progression of periodontal disease. So students, please remember that periodontal disease is something which is of an agent and a host versus reaction. So a lot of that happens because of local factors. It could be because of systemic conditions as well. But then a lot of it depends on how your body responds to it. So the nature of periodontal disease is very complex and very dynamic, and that's the reason why the etiology, the prevention and management becomes all the more difficult and a little tough to understand. So this was just a small attempt for you all to sensitize the basic aspects, what has to be read. And once you've understood periodontal disease in detail, you'll be able to make sense of the clinical picture into a greater extent. Yes, Dr. Jivan, any closing thoughts, any closing points you'd like to add?
Yes, sir. I want to add something to the question asked by Dr. Deepak. Actually, the thing is, as I was mentioning, in the genetic factor thing, that interleukin 1, which is a pro-inflammatory cytokine. So it's understood that it goes to the bloodstream and it go to the bloodstream and it causes the low birth. So that is what I understood, and there may be some other reasons also. So that is the thing I wanted to add. And
all right.
And for
thank you so much. Yes,
postgraduates, so if you are doing some study related to periodontal health, so you should I suggest you to read Karansa. So they have given something about the epidemiology of periodontal disease and what has to be done when we are doing some studies related to periodontal disease, which I wanted to tell. And please use some standardized methods so that we can use the data. If you are simply doing some now and on, we are concentrating more on randomized control trials, but we are lagging in cross-sectional studies. So we need more quality in cross-sectional studies, the data we want, so as a public health professional, so as a public health dentist, we can show that to the policy makers and we can get more programs for the public.
Yeah. All right. So thank you so much, Dr. Bijivin, for engaging in this very interesting session and giving us a quick, rapid revision on the epidemiology of periodontal disease. I'm sure it would be very helpful to most of our participants here. And since they happen to be from different colleges and different years of study, so I'm sure they will take forward this information. And we will also be, having the session has been already live streamed on YouTube. So anyone who's missed out on anything can always go to our PhD 101 YouTube channel and have a look at the video and go for a quick revision. We'll also be circulating the slides of the presentation so that you can quickly reference and go through. So thank you so much, Dr. Bijivin, for taking up the session today and for agreeing to present this topic for us. Anybody else, anything you'd like to ask, you'd like to say? Yes, Jimin, are any of your colleagues, seniors, juniors still there?
No, sir. My students are there, sir.
Okay, that's right. Okay.
Thank you so much, guys. Thank you.
Thank you so much, all dear students. I think you'll have been really supportive and been there and continue to do that for your teachers. I think it's the support from our students which actually keep all of us going in the right direction. So thank you all dear students. All of you stay home, stay safe, and maintain your precautions and practice dentistry in the post-COVID era with all the more care and measures which have to be taken care of. All right. Thank you so much, everybody. We'll see you very soon. Next session, next Wednesday, we'll have another topic. Like I mentioned, y'all can receive the notifications by joining our WhatsApp group. So which has already been, a link has been put in the chat box. So y'all can get free material for public health dentistry from various teachers across the country. So it will really help you in your preparations, be it for your examinations or for a better understanding of the subjects and the concepts. All right. Thank you. Thank you all so much. See you all very soon at the next session. And thank you so much, Bijivin, for doing this.
Thank you, sir. Thank you.
Thank you. Thank you.